talk.
Hello, I'm Dr. Kyung Hyun Kim from Seoul National University Children's Hospital. First of all, I'm grateful for Dr. Francesco Sala, who is the ISPN Scientific Chair, for this great invitation. It's my great honor to present my study to ISPN 2020 virtual meeting. And I would also like to express my appreciation to Dr. Casey Wang, who is the corresponding author in the study. Today, my talk is about the over-exaggerated surgical role in sylvian arachnoid cyst type 3. I have no conflict of interest related to this presentation. Arachnoid cysts are a benign cystic region that are formed by a split of the arachnoid membrane and are filled with cystic fluid. We operate on arachnoid cyst when the patient present with coexisting hydrocephalus or documented increased intracranial pressure, such as papilledema. However, most arachnoid cysts do not cause any symptoms or signs. So there has been debate on the indication of surgery. In some studies, arachnoid cyst surgeries were performed just because of their large size. So in this study, we compared the outcomes of the surgery group with those of the non-surgery group for large sylvian arachnoid cyst Galach type 3. We reviewed medical records of patients with Galach type 3 arachnoid cyst who visited Seoul National University Children's Hospital from July 1990 to March 2018, nearly 30 years. We included 60 patients with sylvian arachnoid cyst whose cases were followed up by more than 6 months. This was a retrospective cohort study. We assessed age, sex, clinical presentation or reason for imaging, laterality of the arachnoid cyst, location, type of operation method, change in size, and clinical outcomes and complications associated with surgical treatment. The median age of the patient was 5.5 years. Mean follow-up period was 7.6 years. As you can see in this table, the number of patients under age 3 was 23, which corresponds to 38%. The number of male patients was 40, 67%. The most common cause of arachnoid cyst discovery were brain CT after fall, 33%, and headache, 16%, followed by other factors such as focal bony bulging, macrocephaly, and seizure. There are 1 patient with papilledema. 77% were found on the left side, consistent with the literature that sylvian arachnoid cysts are more common on the left hemisphere. The most common location was the frontotemporal area. 40% of patients were operated by microscopic fenestration, and 15% were operated by endoscopic fenestration, and 8% were operated by cystoperitoneal shunt. 2 patients showed increased arachnoid cyst size. However, most arachnoid cyst size remained the same or decreased. We divide the patients into 3 groups based on clinical presentation or reason for imaging. 27 out of 60 patients were asymptomatic. Their arachnoid cysts were accidentally found in falls, car accidents. Even 1 was found when fishbone was stuck in the throat or through prenatal ultrasonography. 19 patients complained of ambiguous symptoms or signs to be associated with arachnoid cyst, such as headache, seizure, precocious puberty, developmental delay, or gaze palsy. while 14 patients complained of definite arachnoid cyst-related symptoms or signs, including focal bony bulging, macrocephaly, or carpal edema. We excluded five patients who underwent surgery due to hydrocephalus or papillary edema from the analysis. The remaining 55 patients were divided into surgery and non-surgery groups. Then we compared the results. Usually, the arachnoid cysts were located on the left side, but patients with definite symptom tend to have arachnoid cysts more on the right side compared to the other symptom groups. The midline shift did not show significant differences between the groups. In most patients, headache improved over time, regardless of the treatment of choice. In case of seizure, all seizures have been resolved with anti-epileptic drugs, the surgery group. But in the non-surgery group, there was one intractable seizure. Two patients with precocious puberty showed no improvement after surgery. There was no increase in arachnoid cyst size in the surgery group, but in the non-surgery group, two patients showed increase in arachnoid cyst size, all of whom were under the age of 3. In the surgery group, the size reduction was more certain than in non-surgery group, but the size reduction had nothing to do with the improvement of symptoms. 14 patients who received the surgery had complications, and 8 of them needed additional surgery. In the non-surgery group, no one needed surgery during follow-up period. Here's the table of 88 patients who had complications and needed an additional surgery. We summarized the type of first surgery, the reason for the reoperation, and the reoperation method of those patients. 3 patients with subdural fluid collection underwent cystoperitoneal shunting. A chronic subdural hematoma was removed through a borehole in one patient. One patient with CSF leakage who had undergone microscopic penetration as the initial surgery underwent uroplasty and CP shunting. Craniotomy and subdural hematoma removal were performed for a patient with acute subdural hematoma. One patient who had undergone CP shunting as the initial surgery experienced the CSF overdrainage symptoms, so we removed the shunt. One patient with post-shunting intractable epilepsy received lobectomy and shunt removal with cyst fenestration. We examined whether complications differed with age in the surgery group, excluding hydrocephalus or papillary edema patients. 5 patients, 46% under the age of 3 years, and 9 patients, 41% over the age of 3 years, had complications. There was no statistically significant difference. However, the young patient under the age of 3 had more subdural fluid collection than patient over the age of 3, which was statistically significant. A supplementary analysis was conducted to evaluate the number of reoperations according to age groups. A total of 18 reoperations were performed. 11 patients under the age of 3 years in the surgery group underwent 13 additional operations, whereas 22 patients over age 3 years in the same group had 5 additional operations. Surgery for arachnoid cyst with hydrocephalus or papilledema is generally recommended. Surgery can be considered in patients with symptoms such as seizures, increased ICP, neurological deficit, developmental delay, precocious puberty, and headache. However, the effects of surgery on these symptoms have been debated. A small number of researchers have claimed that all arachnoid cysts have a mass effect and should be operated on to eliminate the possibility of compressing brain tissue, even if there are symptoms. So we conducted research to ascertain whether the Galach type 3 arachnoid cyst is an indication for surgery. In the early days, a large arachnoid cyst itself was an indication for surgery in patients treated by our team. In the 1990s, shunting, a global trend, was the treatment of choice. Later, excuse me. Later, complications such as split ventricle or cyst, shunt malfunction, and infections were observed after shunting. To overcome these problems, endoscopic surgery were performed in the following years. However, in the case of type 3 arachnoid cyst, there was no brain parenchyma at the insertion site of the endoscope. Poor dural closure at the entry side of the endoscope and lack of brain parenchyma often cause the CSF leakage. Therefore, we performed a mini craniotomy to ensure tight dural closure. Meanwhile, since 2000, some parents have rejected surgery because their children were doing well without surgery. Therefore, we held off on the operation and observed the patients for years of follow-up. They continued doing fine. Thereafter, we began suggesting 2 options, surgery or observation, to the parents. In conclusion, when arachnoid cyst patients with hydrocephalus or papilledema were excluded, there was no difference in the outcomes between the surgery and non-surgery groups, regardless of the size of the sylvian arachnoid cyst. Especially for young children, indiscriminate surgical procedures for arachnoid cyst could cause complications without providing benefit. Therefore, surgeons should be cautious when deciding whether to operate or not with Galach type 3 sylvian arachnoid cyst. It is regrettable that we couldn't meet and interact in person due to COVID-19 this year. I hope we can meet in Singapore for the next ISPN meeting. Thank you very much.
Thank you. Thank you for this very interesting presentation. We have no questions by the F&Q thing, but I have one question. Do you think that in the future, an intracranial pressure monitoring, ICP monitoring, as it was presented by Marianne, could play a role in decision making whether or not to operate?
Thank you for the question. Yes, I told before that when we decide to operate the arachnoid cyst surgery, the ICP is very important. So if the patient symptom and monitoring ICP by the telemonitoring, it could be good evidence to we do the surgery.
Okay.